Good morning, all. We'll start the program in another 5 minutes. Or if we hit more than 50 participants, we'll start with the event. So thank you for joining in. So please excuse. We'll wait for another 5 more minutes. So good morning, all. I think we have hit around 60 participants. So I think we'll start with the program today. Dr. Siddhi, are you there?
Yes, so good morning. I'm very much here.
So I think we'll get started with the event. So I would request Dr. Siddhi Tripathi. She is a professor in the Department of Prostho at IIS Ghaziabad. She did a BDS from JSS Dental College, Mysore, and MDS from Ambedkar Dental College, Bangalore. She has a teaching experience of over 13 years. And she is an integral part of the upcoming national conference, our 14th National ISPRP conference. She is a part of the organizing committee. So I would request Dr. Siddhi Tripathi to welcome the gathering as well as to throw some light into the upcoming national conference. Thank you, Siddhi. Over to you.
Thank you, sir. Very good morning once again to one and all present here. And I take this opportunity to welcome all of you to this webinar hosted by ISPRP on this resplendent Sunday, that is 26th of May, 2024. It's my proud privilege to welcome the speaker for today's webinar, Dr. R. Vishwachandra, the moderator, Dr. Mahesh, and all the participants who joined us today for this webinar. And I would like to express my heartfelt gratitude to the President, ISPRP, Dr. Gopi Chandra Sir, the Secretary, ISPRP, Dr. Vibha Shetty Madam, and the Scientific Chairman, Dr. Manuel Thomas Sir, for giving me an opportunity to present this welcome address. Thank you, sir. Now, before moving to the scientific deliberation, I'd like to share that the 14th National Conference of Indian Society of Prosthodontics Restorative Periodontics would be held at ITS Center for Dental Studies and Research, Ghaziabad, from 12th to 14th July 2024. And this conference, let me throw some highlight that it's going to be an academic extravaganza with keynote lectures from guest speakers of national and international repute. It will have a culmination of pre-conference courses, the panel discussion, the scientific paper and poster presentation for the registered delegates. There'll be trade area, your themed banquet night, and multiple activities to enhance your enriching your academic learning experience. So I would request all of you to please register for the upcoming conference and pass on the message to the colleagues, your students. The registrations are open for the interns as well as the postgraduates, the faculty from all three specialities. The early bird is now already over, so you can avail the second category, that is the registration up to 30th June, utilizing this particular barcode and filling up the Google form also that is shared along with this, the brochure. So I assure you that this conference will be 3 days of enriching experience for all of us with some amazing memories. So we at ITS Dental College are looking forward to welcoming all of you for the upcoming 14th National Conference. Thank you, everyone. Over to you, Dr. Manuel.
Thank you so much, Siddhi, for enlightening us on what is to come in July. So the link for the registration I will be sharing with you guys later. So now let us get into the scientific program of today. So I would now like to just our moderator for today's program is Dr. Mahesh. He is an associate professor at MCOTS Mangalore. He did his BDS from Yennapoya Dental College, MDS from MCOTS Manipal, and he is also a certified oral implantologist. He has over 40 peer publications in peer-reviewed journals. So I'm really thankful for Mahesh for agreeing to be the moderator for today. So Dr. Mahesh, over to you to introduce the speaker for today, Dr. Vishwachandra.
Thank you, Dr. Manuel. A very good morning to one and all. It's my pleasure to introduce our speaker for today's webinar on platelet concentrates preparation to application by Dr. Vishwachandra. Dr. R. Vishwachandra is currently working as professor and head in the Department of Periodontics at SVS Institute of Dental Sciences, Mahbub Nagar, Telangana. Dr. Vishwa has done BDS from AME's Dental College and Hospital Raichur in the year 2002, MDS from Manipal College of Dental Sciences, Manipal in the year 2005. Doctor has also done DNB in the year 2009 and further went on to do PhD from Commonwealth Vocational University, Kingdom of Tonga. Dr. Vishwachandra is also recipient of K. Chiranjeevi Medal for highest score in periodontics in the final BDS exam held by RGUHS in 2001. Dr. Vishwachandra has more than 40 publications and published a textbook and also has a patent to his credit. Doctor has conducted and guided various funded research projects. So here I welcome our esteemed speaker, Dr. Vishwachandra, to this August gathering webinar on platelet concentrates preparation to application. Over to you, sir.
Thank you so much, Dr. Mahesh, for the introduction. Thank you so much, ISPRP, for the opportunity given. Thank you so much, Dr. Manuel, for constantly being in touch and sort of like driving me into speaking on to this topic today. Before, without wasting any time, let me just start my presentation. Manuel, can you just allow me to share
Yes,
the screen, please?
I will stop sharing the screen and you can start
Yeah,
with
yeah.
your
Thanks so
screen share.
Thanks so much.
Thank you. And small request to all the participants, once the program is there, kindly mute yourself, and any queries you have, put it in the chat box in the Zoom, and the queries will be asked by our moderator to the speaker at the end of the event. So thank you so much, everyone.
Good morning, everyone, and thank you so much for making it on today's Sunday's morning. I really appreciate your presence. And again, my double thanks to ISPRP for giving me this opportunity. So this is a topic that I've spoken quite a number of times. I generally share most of my presentations onto online platforms. And again, I'm very glad to speak on this topic that is extremely very close to my heart, something that I've worked on for quite some time, something that I've held a patent on, and something that we've been developing, since the past 2 years after the onset of COVID. So, especially the topic on centrifuges or the use of and the development of centrifuges is one topic that is very close to my heart, though that is not the crux of what I'm going to speak today. But so this is a topic I just would like to reiterate that something very close to my heart and something that I sort of like keep on speaking about. The most important thing is this saying actually. So all of you who have seen the movie, Kung Fu Panda, you would probably remember this. You would probably know, where the master actually he basically says, yesterday is history, tomorrow is a mystery, but today is a gift, and that's the very reason why it's actually called as a present actually. So this is actually a very apt saying, primarily because this is a good time to be into regeneration. This is a very good time to be into, let's say even hard tissue regeneration or even soft tissue regeneration. And this is something, we are in a very beautiful time, primarily because we have so many products. We have a lot of autografts, we have a lot of allografts, xenografts, alloplastic substances. But, PRF is something that made some things very easy, primarily because as I would like to establish this point on why this is actually called as a present in the subsequent slides, PRF is something that makes you do a very predictable regeneration, let's say, at the equipment that is not quite expensive, with a protocol that is not very difficult to learn, and with probably it doesn't take much time at all, honestly, to even perform, to regenerate, and to basically sort of like deliver PRP or PRF or any platelet concentrate for that matter into a specific site. So that's the very reason why this science of platelet concentrates is indeed a very big present to especially all the specialties. Because as a periodontist, I do understand that bone grafts and all, it's essentially a domain of one or two specialties. But PRF is something that has been taken a big time, because we also speak about endodontists doing regenerative endodontics, with IPRF gels. We speak about implantologists, we speak about prosthodontists. So everyone has taken up, this concept of platelet concentrates. So that's the very reason why I would really like to call it as a present to dentistry as such. Okay, but let us try to understand why this is a present. What are the prevailing concepts? And what can we do from our side actually, to further take this concept into a next dimension or to the next level? Okay, I'm pretty sure most of the listeners must have listened to a lot of topics on let's say even platelet rich plasma, platelet rich fibrin, and so on and so forth. But again, I would like to probably discuss the importance of platelet concentrates under four headings. Probably, let's have a small overview on what this concept is all about to someone who's really not introduced to this specific topic. Okay, let us speak about some of the milestones that we have actually encountered let us see what progress has been made, especially with respect to classification, especially with development to protocols and so on and so forth. At the same time, what are the issues? I mean, you see a lot of articles, we see a lot of articles on the use of PRF here, the use of PRP there, and this thing and that thing. Okay, but what does the research literature actually says about, the very importance of using all the platelet concentrates? Before we actually go into the topic per se, let us give some respect. Okay, let us pay some homage to this very humble but very important cell, which is called as a platelet, which unfortunately does not survive the very moment it discharges its function. So this is something we know that the platelet is actually, sort of like a slightly larger cell. Okay, it has four very specific areas in its cell per se. Okay, so it has a very clear, sort of like a very peripheral layer, sometimes called as the membranous layer of the platelets. It has what is actually called as a sol gel layer. Its cytoplasm is something like agar actually. It generally tends to liquefy as well as solidify at the same time. It has clear cut what is called as granular layer, because where it has a lot of alpha, beta, gamma, delta granules and so on and so forth. It also has something called as a tubular layer. A tubular layer is something, all the thing that is made by the Golgi apparatus, the most of other microtubular apparatus that you actually see. Okay, now what actually makes platelet a very important cell is something that we know is basically primarily a cell which basically contributes to what we call our hemostatic mechanisms. So we very well know what a platelet will do, but just as a small overview, so let us just sort of like freshen our knowledge, just brush up on what a platelet can primarily do from its side, from its outer surface. From its outer surface, we very well know that it is a very rich in glycoproteins, so which basically helps in the adhesion of platelets to various blood vessels. It also helps in activation. Most of the glycoproteins actually, they basically interacts with the fibrinogen in blood, actually binds a lot of clotting factors. You look at fibronectins, vitronectins. So this is something that is the outer layer, primarily, especially the glycoproteins, the 2s and 3s and this thing. They basically, play a very, very important role in the activation and the adhesion of platelets to, especially wherever there is a wound where its function is primarily required. Probably the next most important cells are the granular cells, where we have a lot of granules. It has a lot of granules, especially the granules that we basically are looking at are the alpha and the delta granules. The alpha granules actually are very famous for releasing the growth factors. Any periodontist actually, you will probably know what are the growth factors that are fundamentally released. Okay, so we are really talking about all the platelet-derived growth factors. We are talking about transforming growth factors. We're talking about the insulin growth factors. At the same time, we're also talking about the vascular endothelial growth factors. We're talking about epidermal growth factors, fibronectins, fibronectins, you name it, and it's there essentially. Most of it from the alpha granules. At the same time, the delta granules actually they release ADP and ATP, calcium, serotonins, okay, which basically play a lot of role in the clotting cascade. So, in a nutshell, actually, the platelet has everything. The platelet has everything where it actually contributes to a scar. It actually contributes to a cicatrized area, and this area is very rich in growth factors. So that is something. This point is something that has been, exploited, especially by dentists and by other specialties too, but especially by dentists. So let's have an overview on how this happens, how this is done, and what are the directions that we can take fundamentally from this. This is also something that I basically like. So, why is the very reason why we have used platelets? Because if you remember in the previous slide, so I basically told you about all the things that are actually released by platelets. So, the very reason once we can actually harness this mechanism into a specific protocol, basically generate a platelet concentrate. What can this concentrate do? This is something where I would like to point out, especially the concepts of tissue engineering. I'm sure most of us are familiar, but just in case if you're not very thorough with these concepts, let me just highlight, tissue engineering is something where we want three things in our mix, actually. Okay, so we basically want cells, we basically want growth factors. At the same time, we also want a nice scaffold. Okay, so most of the times, if you are looking at grafting, if you are looking at, regenerative materials, we basically get only one. At maximum, we can probably get two out of three. Most of the times, it's the cells that are missing, unfortunately. Okay, so this is something, because I remember reading in one article where basically said if you're using a platelet concentrate, you're actually doing tissue engineering without realizing that you're actually doing tissue engineering. Why? Because it's a very low effort mechanism. I'm sure most of us should know is basically how to, obtain blood. Even if you don't want to do that, there's a technician around whom you can harness for this talent. Okay. The next thing is run it into a centrifuge, and you have a material that can basically satisfy almost all the criteria that we basically require for the concepts of tissue engineering. For example, what does a PRF or what does a platelet concentrate for that matter? What can it do for us? If you look at the very first thing, we already have a scaffold. It is a very nice, dense fibrin network, a uniform fibrin network. Okay. It has a lot of cells. Generally, most of the times, it basically has activated or destroyed platelets, if you can call it. Most of the times, they basically have leukocytes and monocytes. They may not be regenerative cells, but their importance in primarily cleaning the wound and actually creating an hypoxic environment so that the regenerative process can kickstart. It cannot be underestimated. At the same time, once the clot actually matures, you can also see a lot of alveolar bone progenitor cells, for example. At the same time, probably the most important role of using a PRF or a PRP is its uninterrupted growth factor release. For example, most of the studies, they basically say that you can see a growth factor release as early as 6 hours, and it actually tends to go for 14 to 15 days. One article even says it's there for 26 days, but at least in our department, when we actually did a couple of dissertations, actually we were able to see a very predictable growth factor release, at least for 14 days at least. Okay, so this is something that all of us must remember in mind when you're doing a PRP or PRF procedure, whatever procedure which basically involves the use of platelet concentrate. We're not doing a very simple reparative procedure or a very simple regenerative procedure. Okay, so we basically are doing a proper tissue engineering procedure subject to our protocol actually becoming being correct, and being within the framework of generating what you call a platelet concentrate. And this point and this clot that we actually got is not a very simple thing that is going to dissolve like a normal clot. I'm pretty sure most of us know that whenever there's a wound, whenever there's a normal clot formation, the clot it generally tends to starts to dissolve in about 3-4 days. By the end of 7 days, you can see a very big scar actually. Then the scar will start to contract and this thing and that thing. Okay, but if you fundamentally look at what you call PRF, especially platelet concentrates, all the platelet concentrates for that matter. Okay, so one beautiful thing about this clot is that it is a fibrous clot that generally it doesn't sort of like shrink or dissolve just like a normal body's own clot, because you are generating it with a proper protocol in a proper apparatus using proper armamentarium. The most important thing is it has basically three things. The first thing is this clot is not going to dissolve because one of the growth factors in it, which is the transforming growth factor beta 1, sorry. So it basically results in a very proper cicatrization. You're not going to lose this clot as you lose a normal body clot. Okay. At the same time, uh, what we should not forget is we also do some sort of a stem cell engineering with this. That's, if you remember the very second slide that I told you, this is a present. This is a present for the very simple reason that this present actually comes in the form of two things. The first thing is we can do some form of tissue engineering without any big effort. At the same time, this is also something where we have there's a lot of sort of like a stem cell engineering where the clot itself can stimulate a loss of mesenchymal cells. So, for example, we are looking at the most important thing for us is bone at most of the times, at least. Okay, so we are looking at most of the cells from osteogenic lineages. So that is something. At the same time, the beauty of this is the insulin growth factor that you actually find, in a platelet concentrate. It also, sort of like is known to be a cell protective agent. It's known to be an anti-apoptotic agent, and it generally prevents what you call any apoptosis. So what we have here is a nice material that fundamentally satisfies the criteria of tissue engineering. At the same time, it also satisfies at least the initial criteria of doing stem cell engineering. That's why if you basically look at it, this is not a new concept. In fact, when I was in my PG 2005, I never heard of anything from a platelet, something from a platelet concentrates point of view. It was only in 2007, 2008 that we started basically to listen about the role of PRF. Fine, it made its effort, in sort of like a lot of cosmetic procedures, including hair transplantation, this thing and that thing. But that was the first time that we started hearing about PRPs. It had a very specific timeline. In fact, the timeline is actually very interesting because the very first 40 years of platelet concentrates have been very sort of like very sketchy. They have been like very murky. And there was not very much work, especially in relation to trying to identify what sort of material a PRF actually was. So there were a lot of this protocol, that protocol. Let's do this and let's do that. But so this is something that requires a bit of an overview. So this is also something that is very interesting and something that that we should really actually have a look. Okay. So the concept actually came in 1954. Okay, it was by a person called Kingsley. So they basically first started to separate blood, fundamentally to separate blood to isolate the various growth factors that are normally found in blood clots. So they basically gave the name initially something called as the platelet-rich plasma. Though there were a lot of competing, let's say, innovators and competing scientists who fundamentally worked on this. So they gave a lot of different names such as fibrin glue, gelatin, platelets, and so on and so forth. Okay, it was, if you basically look at it, I'm jumping from 1954 to 1986 because basically at the same time the lack of centrifuge technology probably when it came to preservation of blood and this thing and the thing, there were a lot of roadblocks. So essentially, even the development of the concept of platelet concentrates was actually very less between this period. It's only 1986 then with the advances in medical technologies and this thing and that thing, that this concept actually sort of like started to develop and started to increase in magnitude. For example, there are a lot of authors, especially by Kingsley himself, again, who gave the term PRP. Again, we are looking at authors, such as Knighton and Marx. They basically started to, sort of like delve a little bit, especially in the histological level, to see what exactly is this material about. What are the various growth factors that we actually see, and what are the various advantages of this material, and a couple of things like that actually. So this was also the first time where there was an attempt to basically, sort of like to optimize or to standardize the protocol behind the development of PRP, especially. PRFs came a little bit late, which is actually in the very third point. Uh, they were called as second generation platelets because, as I'll probably explain to you in the subsequent slides, there's no big difference, especially from the first generation platelet concentrates. It was primarily PRF, and the protocol was also extremely optimized to basically account for some legal loopholes or to account for some legal restrictions that were actually present in some countries behind the use of bovine thrombin, calcium chloride, and a couple of a couple of things. Especially when it came to the release of PRPs. So 2000 actually we started to listen about PRFs again by Chokron. I'm sure this name is very familiar to most of the persons actually who are basically handling PRF right now. Okay, basically a pain therapist, and he basically, especially in France, apparently because they could not use thromboplastin, they could not use calcium chloride, they could not use bovine thrombin. So this was actually the protocol was developed. If I'm sure most of the listeners would know that PRP is essentially a two-step protocol. It's a two-stage centrifugation protocol. It's also something that may require at least some PRPs. I will tell you what are those PRPs that basically require a refrigeration protocol. Even that is required. So to basically to offset all these apparent disadvantages. Okay, so we have had a second generation concentrates which were actually called as PRFs, and by 2009, so we could see a proper establishment of hierarchy in platelet concentrates. So we had something called PCs, as the title goes. So we had platelet concentrates. We also had something called as APCs. So apparently, which were called as advanced platelet concentrates. Some people even prefer to call this as activated platelet concentrates. This was also a time when people tried to classify because, as you probably know, one very bad habit or good habit or whatever we look at it is for researchers or for anyone, for any person with an academic background, is to classify what these things are. So, in fact, the very first classifications on pieces, imagine it's a 1954 and almost 50 years later. So, there was an attempt to actually classify these things based on the growth factor released, based on the morphologies per se, and a lot of, and a lot of factors as such. So, finally, by 2014, so there was a lot of studies again. So, which was said, that the original protocols, there seems to be some issues actually. So, we have to rectify this. There have been a lot of technological advancements. We can't just sort of like follow protocols that have been laid down in 1954, 1960s, and this thing and that thing. So let's try to modify this protocol and let's try to make it into something called as, let's try to generate some new protocols. Okay, so one such protocol, so now we see what is called as a derived pieces or something called as a derived platelet concentrates. Okay, so let's actually see what all these are and try to understand what these things are. Okay, so we are still with milestones. So now we are in the second generation platelet concentrates. Okay, so I'm sure most of you know that when we basically run what do you call, when we take about 8 ml blood or so and basically run in a centrifuge, actually we see three very clear layers. The first layer is something called as a corpuscular layer, sometimes called as the red layer, sometimes called as an RBC layer. The next layer, actually, the one slightly in yellow here, is something, and there's generally something called as a small buffy coat between these two. A buffy coat is generally a mixture or the interface between the growth factor rich region which is the desired region of actually, getting of actually doing a PRP or a PRF procedure per se. Over that is something we call as PPP or platelet poor plasma. It's also something called as growth factor poor plasma. So whatever you run, whether you run a PRP protocol, whenever you run a PRF protocol, actually these are the three layers that we generally see to varying degrees of thickness. For example, you might ask me actually, so why is that we actually have a second generation platelet concentrate when the first generation was doing its job? So even if you look at this picture, actually, if you compare all the test tubes fundamentally are of same size, volumetrically, if you compare all these things actually, so you can actually see the desired layer, the one in yellow with a lot of growth factors, with a lot of growth factors. Let it be any protocol, let it be a PRP protocol, let it be a PRGF protocol, let it be a PRF protocol. So the thick layer or our desired layer in between actually with the buffy coat is the thickest when it comes to the second generation platelet concentrates. Of course, there are some fundamental, even physiological and physical differences between these two. But if you basically look at any article and say, why are there a second generation platelet concentrates? A lot of people will try to tell you, or the first thing that is going to be said is that when we have optimized this protocol, we are trying to obtain the maximum volume of the desired part from that fixed quantity of blood. So it's always said, that the second generation pieces are the same cells, the same blood, and this thing and that thing. But the only thing is we have refined the protocol in such a way that we are actually seeing a lot of desired products that are to our fundamental benefit. Okay. So even if I use a very fancy term such as platelet concentrates and this thing and that thing, okay. So let's not forget that we basically look at two things fundamentally, at least in dentistry. We only have two things. We have something called as a platelet-rich plasma versus the common thing that is basically used in most of the dental colleges today by most of dentists, most of clinicians, is the use of platelet-rich fibrin. There has been a specific reason why we have slowly shifted from PRP to PRF. Actually, there are studies even which still use. There are clinicians. At least I'm from Hyderabad myself, so there are clinicians in Hyderabad who still prefer a classic PRP protocol over a PRF protocol. They're not wrong, but at the same time, there are some obvious advantages behind using PRF, especially over PRP. The first thing is the use of bovine thrombin and calcium chloride. I'm sure most of the listeners would probably know that PRP is a two centrifugation protocol. So you'll have to centrifuge again. Actually, the very reason is you are really trying to maximize that area that we require. Actually, you're also trying to get, sometimes it's called as the PRGF layer, or the platelet rich growth factor region. Some people even call it as plasma rich in growth factor region. So there are a lot of confusing names actually. So if you look at PRP, it's a two centrifugation protocol. You have to run the centrifuge twice at the same time to basically induce the formation of a proper clot. You're looking at a bovine thrombin, and you're looking at adding bovine thrombin, sometimes even thromboplastin. Sometimes, you're even looking at adding calcium chloride. I even tried to find out the legality of doing this in India. Actually, apparently, we don't have any laws which basically say that, that you don't have to add bovine thrombin, or if there's any law against adding bovine thrombin or calcium chloride. Please correct me if I'm wrong, but at least from what I have found, actually. So you're perfectly okay, at least legally, in actually doing PRP. But in some countries, apparently, like in France and most of the European Union, and even in a lot of Middle East countries, and especially Turkey, I guess, actually. So they have this protocol that you're not supposed to add this without patient's consent, especially considering that bovine thrombin and all can be, sort of like, need not be from the same individual. They can be, of different origin from different humans. So there are very specific legal loopholes that you cannot escape for some matter. At the same time, when you look at PRP, the procedure can happen very fast. Even if it's a two centrifuge protocol, you generally see a very sudden fibrin polymerization. And this fibrin polymerization and this clot formation being extremely fast, you generally end up with a rigid network rather than with a nice pliable thing. For example, I'm sure most of you know that PRF can be compressed into a membrane. It's sometimes very difficult to actually compress. You can't do anything with a PRP clot. Sometimes, unfortunately, okay, the network can be very rigid. You can only compress it actually to sort of like extract the liquid from it. But PRF, you can retain even the fluids inside, even if you compress it. Actually, apparently does not happen with a PRP. At the same time, the corpuscular layer is fundamentally very resistant. It can be sort of like, it can be very hard. You can't use it for anything. It's not that we use the corpuscular layer in PRF in itself, but this is an obvious advantage of using, PRF over PRP, because PRF, the centrifugation protocol, most of us will know that it's a very slow natural polymerization network. Okay, we have a very flexible fiber network. I'm sure most of you know you can use it for socket preservation. Put it in a small receptacle that comes with the box. Actually, you can just put it and nicely compress it and so on and so forth. That can be done. At the same time, you can also compress it into a membrane. If you don't want to do that, you can actually cut it verbatim and nicely put it in the defect itself. So these are the obvious advantages, of actually using a PRF over an obvious PRP. So again, a little bit of facts, for someone who loves the theory behind, PRPs and PRFs and most of the platelet concentrates. Okay, so this very nice article, something that I put at the bottom actually by Ehrenfest. So a lot of articles by Johann Ehrenfest actually. So this was in Journal of Paleontology, 2010. Classically, we are looking at 4 families, especially. Okay. Well, so from this point on, I'll be confusing you a lot actually because a lot of terms, there are PPRP, there's LPRP, there's PPRF, there's LPRF. There's also something called as PDWGF. There's something called as, lot of variants. So please try to be with me. Anything else, please try to put a comment actually in the comment box if you lost me somewhere. This is something that's very confusing even for me too sometimes. Okay, the only thing I remember is LPRF. That's the reason why I've actually highlighted it in green. Otherwise, the other three I generally tend to forget. It's been ages since I've done PRP myself, mostly into PRF, but especially so this Sunday afternoon, let's try to remember some historical facts at least. So the 4 families are something like that. The first thing is our PPRP, sometimes called as pure PRP. So if you basically look at this picture, okay, so we are looking at pure PRP. We're only looking at this layer, okay, which is called as a buffy coat. So buffy coat is an interface between the fibrinous layer, the layer in yellow here, the fibrinous layer, and the RBC layer. Apparently, it's formed by the interdigitation of the RBC layer and the fibrous layer. It's extremely rich, especially in the cellular elements. This is where you can see a lot of leukocytes. Leukocytes may not be a regenerative compartment, but leukocytes, they help fundamentally, in cleaning up the wound and this thing, which is different as the subsequent activities. So this is also the area where, because of the effects of gravity, the growth factor molecules tend to sink in. So this area is something, that is extremely very rich in cells at the same time as growth factors. So this was classically called as, the PPRP region, pure PRP region, actually. But at the same time, let's not forget that, there's this much big area, actually, this much big area. There's no point in trying to, only obtain this very small region as if the rest of it is essentially useless or something. So this has led to something called as an LPRP concept, sometimes called as leukocyte-rich PRP concept, okay? So this is not something that is very different, actually. What we basically do is we don't try to take the buffy coat here. We don't try to concentrate too much on the buffy coat because apart from leukocytes, there are also RBCs in this region. We don't want RBCs. So what we do fundamentally is, especially for PRP, I told you that PRP, we run the centrifuge twice, in some protocols even thrice. So what we basically do is once we generate the test tube, we slowly take off this layer, especially the layer, especially between, the fibrous layer, the PRGF or, the platelet-rich and growth factor region and the PPP region. So we again take it into another centrifuge and we fundamentally run it. Okay, so we actually centrifuge this region twice. So what happens is this region actually narrows because of the effects of gravity. At the same time, we generally tend to increase the amount of leukocytes that are actually present. So this concept was actually called as LPRP. So fine, once when the concept actually started to shift from PRPs to PRF, so original concept was again called as PPRF. So PPRF is nothing much different between LPRP and PPRF apart from the fact that we run the centrifugation cycle once to obtain a very nice thing. If you basically look at these both pictures, this green and this orange regions are actually more or less the same. Only thing is in LPRP, we actually run the centrifuge once. We gently pick these layers and run the centrifuge twice. Whereas in PPRF, I'm sure most of us know that we basically, sort of like run it only once and we only use this region actually. So that was the reason why it was called as PPRF. PPRF is now called as SPRF by some authors. It's also called as a standardized PRF protocols by some authors. At the same time, what we prefer most of the times and what I remember most of the times is a classic LPRF protocol. Again, if you remember the saying, history repeats itself. Okay, so again, we are looking nothing but PPRP, but where the certification cycle is different. That's the very reason why I keep on insisting, the only difference between first and second generation is how we basically harvest this fibrous clot. Otherwise, if you look at most of the centrifugation cycles and this thing and that thing, it's more or less, there's only difference in centrifugation cycles, but our regions of interest, the regions that we basically want is more or less the same. Again, we are looking at what you call this region. We are looking at the Buffy coat region. So these are the classic four families actually. Okay, so of PRP. Of course, if you are shifted from PRF, okay, we have basically two, and there are something that are derivatives of this PRF, something that I'll be speaking about shortly. Of course, like any good topic, the topic of platelet concentrates, we have a lot of classifications, we have a lot of products, we have a lot of protocols. There are a lot of original protocols, there are a lot of derived protocols. So next 20 minutes or so, kindly, let me actually go, sort of like speaking about on these topics. Okay, so let's look at some of the classification systems. Okay, so again, the same thing, something that I have repeated just now. Okay, so we have platelet concentrates. So this term was given in 2009 by Ehrenfest. Doran Ehrenfest is his full name actually. So fundamentally, because people were using some very random terms. Okay, apart from PRP, PRF, we had something called as platelet derived wellness products. It doesn't look very professional, but we have had a lot of different sort of like different terminologies. So it was basically said, let's not use any terminal that we want. Let's group all the platelet concentrates into one solid and one unified heading, okay, which we can call as platelet concentrates. So the classic platelet concentrates, so we had something called as pure platelet concentrates such as PPRP, the pure platelet rich plasma, or we had something called as a PPRF, or a pure platelet rich fibrin. Of course, I have just told you that if you are specifically looking at for leukocytes as well, or any other cells that also contribute for initial repairs, we have also had something called as a leukocyte-rich preparations or leukocyte-rich platelet concentrates. So we are looking at LPRPs. We are also looking at LPRFs. Okay, so this was something that was a very fundamental classification. If you remember one of the previous slides, where I was speaking about the various milestones in pieces actually. So this was something, this was from 1954 to 2009, there was no classification whatsoever. So people just gave their own protocols, some very stray case reports, and this thing and that thing. But ultimately, in 2009, let's say, fine, let's have very two gross headings: the pure protocols and the protocols where we are also looking out for leukocytes in our platelets mix. Of course, this started to evolve because as you probably know, we can't use a fibrin clot every time. Okay, so we can't use a fibrin clot every time. We have platelet concentrates. We have platelet concentrates with a lot of what do you call in a lot of forms. We have a lot of applications as well. Okay, so we also wanted to sort of like we also sort of like wanted to know uh, whether this can be actually used in various forms. Okay, so this was a classification given by Mishra actually. Okay, so Mishra actually gave a classification where they basically said uh, we are using platelet concentrates a lot in sports medicine now. Okay, we are using it in sports medicine, and let us try to apply this concept. Not in whether it's actually sort of like a LPRP or a PPRP, whether we can actually apply this in various physical forms. For example, his classification, if you look at it, so he basically calls type 1 PRP as an LPRP solution. Okay, so type 2 PRP as an LPRP gel, type 3 PRP as a PPRP solution, and type 4 PPRP as a PPRP gel here. I'm sorry, as a PPRP gel. Sorry for the typo there. Okay, so in fact, if you basically look at this classification again, okay, so this was a classification where an attempt for the first time was made to actually classify platelet concentrates, to actually platelet concentrates into various physical forms. Now we speak about IPRF. Now we speak about a sticky bone concept, a stinky bone concept, a sticky bone concept. We speak about PRF membranes. Okay, but at least in 2012, so let us realize that there has been a very nice classification. There has been an attempt to actually sort of like classify all these into different physical forms, not the forms that I've been speaking about. Whether they are rich in leukocytes and so on and so forth. At the same time, there was other classification. This was always around 2014, 2016, which was actually called as DEPA concept. Now, DEPA concept is they basically said, why are we so concerned about whether it's PRP or PRF or something? What we basically require is how much amount of cells we used initially. So how efficient was this production? Okay, so this becomes very important if you would like to sort of like think about the centrifuge that we use. Okay, so this itself is a very big concept. I've spoken a lot about the use of centrifuges in PRF, how to optimize your centrifuge and this thing and that thing. Okay, so they basically used to say that to get a proper PRP or to get a proper PRF, the minimum amount of platelets should be at least 5 billion. in about 8 ml of blood. Okay, so unless you are reaching that 5 billion mark, you definitely can't get a very nice sort of like, a very nice platelet derivative. That was one thing. And next thing is, fine, you have a 5 billion platelets in your mix. Okay, but 90% of these platelets must have been used in your mix. Okay, so 90% of your platelets must have activated or should be activated for you to derive any platelet concentrate. Okay, so the next thing was in the DEPA, the next thing was the efficiency of the production. How efficient was this production? So how did you actually use and this thing and the thing? Okay, and the third thing was activation. Fine. Are you adding something? For example, let's say, are you adding something? So if you remember in PRP and all, we basically add a lot of things in PRF, we don't. So what is the effect of this? What is the effect of this activation? Are we losing some cells actually? Are we losing some growth factors? So this was something that was also considered to be extremely important. At the same time, the purity. Of course, we basically know that, even the host systemic status, okay, the type of centrifugation protocol, the amount of time that is basically required for you to, sort of like get cells, the time required or the time that is taken for you to harvest the plate and even to run the centrifuge also will determine what is the purity of your mix. Okay, so these were all the facts that were considered to be extremely important. Okay, so this was actually called as a DEPA. So dose of injected platelets, efficiency of the production, what was the purity, and what was the activation actually. So all these four things were also considered to be extremely, extremely important when it came to the entire thing. There's a Yomo bigger classification around the same time. Okay, this is something called as an ISTH classification, sometimes called as the International Society on Thrombosis and Hematopoiesis and so on and so forth. Okay, so they gave their own big classification. Okay, but there's some very interesting things in this. Actually, let us not go very deeply into sort of like this table per se. But again, just to confuse you even more, remember this, look at this term. So we spoke about PRP. We know what is LPRP. We spoke about PRF, we spoke about PPRF, we spoke about what is LPRF, and so on and so forth. At the same time, look at these terms. They also have introduced terms such as red PRP, okay, red LPRP, red PRF, and red LPRF. So, what is the difference between our classical PRP? Our PRP, okay, we know it's a lot of hues of yellows and reds actually in the PRP that we basically generate. But what is this difference between this PRP and red PRP? Okay, so if you look at red PRP, okay, especially they basically say that, that if you look at the PRPs, we basically use a lot of desktop centrifuges. We use a lot of desktop centrifuges to basically obtain PRP. At the same time, there are a lot of other very larger equipments, very specialized equipments. Okay, we can also use cell separators, like how they use in blood banks and so on and so forth. You can also use selective infiltration techniques. You can also separate cells using a cellulose acetate membrane. Also, even that is possible. The same equipment that is used in dialysis, which is actually so. They basically said, that let's not limit ourselves only to centrifugation. Let's also try to inculcate other advanced equipment such as cell separators and autologous selective infiltration and thing and that thing. The fundamental difference between sort of like using centrifugation from any advanced equipment is look at the platelet concentration here. So when we basically use equipment such as a non-centrifugation equipment such as cell separators or autologous separators, the cell count is much higher, much higher. Remember, I was using the word 9 billion before. I basically said it should be actually 9 billion actually for 8 ml of blood. So this is something that goes way beyond 9 billion. We are also looking at 17 billion to some extent in about 10 ml or 8 ml of blood. Okay, so that is fundamentally why they have put this classification. They say, look, please don't limit yourself to a centrifuge. Please try to go to advanced equipment so that you can get high number of platelets. Remember the DEPA classification I spoke about actually. So please ensure that the dose of injected platelets is much more higher by using this equipment. At the same time, we also would like to see some platelets. So by now, I'm pretty sure all of you know that LPRPs or leukocyte-rich preparations would obviously have a lot of platelets. So this was one classification which basically harped or which basically tried to, sort of like tell us the concept of using, don't just limit yourself to centrifuges. Also, please try to use some advanced equipment. So we just finished milestones. So let's look at some of the protocols that we fundamentally try to do. Okay. So this is a picture of the moon. So I'm pretty sure most of you know that there's the far side of the moon. The far side of the moon is not something that we basically can see. Why? Because it perfectly, the rotation of the Earth, unfortunately, matches to the rotation of the moon in itself, actually. So there's one side that we obviously see, the other side that we never see. Okay, so we have some very nice protocols, actually. So we have something called as standard platelet concentrates. This is something that I've been speaking about probably in the first half of this presentation. So I'm sure I must have probably sort of like put some framework on what is PPRP, what is the importance of LPRP, what is PPRF, and what is LPRF. We also have standard protocols based on four very important things. I'm sure because when I go for Vivas or sort of like as a PG exam or something, my one of my favorite questions is, you tell me how do you basically generate a PRF. So people generally tend to say, so it's 2,700 RPM for let's say 10 minutes or 11 minutes or 14 minutes or whatever actually. So the most important thing here is the protocols actually are dependent on four things, not just a single thing actually. So the RPM and time is something that most of us will remember, but also very important in this conjuncture is the angulation of the tubes, and the G force that actually the centrifuge can generate. Because if you look at most of the Chokran's original articles, he basically says that for PRF, your RPM should be 2,400 RPM. Your time should be between 10 to 14 minutes. The angulation should be 37 minutes. And the G force should not exceed 400 Gs actually. But if you look at most of the centrifugation, okay, people sometimes, even I for that matter, in some clinics, I'm forced to use a normal laboratory centrifuge. The tube angulations, most of them can be anything from 0 to 90. Okay, the G force, I'm pretty sure, will be somewhere in the vicinity of 1200 to 1800 G. So these are not something, though the protocol is standardized, sometimes very unfortunately, the equipment is not standardized. So that is something that all of us must really be aware. Even if the RPM and the time is under your control, most of the times, in most of the centrifuges, sorry, the angulation and the G force is definitely not under your control. So that's something that we have to remember. So keeping this in mind and trying to, sort of like tailor make or trying to, because PRF at one point of time was used by very narrow specialties, probably, especially by people who were mostly into heart tissue regeneration. Then slowly we sort of like realized, this is not something that can be used only by one specialty, and this can be used by various specialties as well. So slowly, as we shifted to implantology, slowly as the branches of periodontology, oral surgery for that matter, and as the branches of tissue engineering that delve in tissue engineering in itself, once they started to evolve, we started to see a lot of something called as derived platelet concentrates. Okay, I'm pretty sure some terms are fundamentally familiar to you. So CGF, we have something called as a concentrated growth factor, which is somewhat similar to the PRGF concept. Okay, so we now have a titanium PRF, so where PRF is now generated from titanium tubes. Okay, we have an IPRF, which is an injectable PRF. We also have something called as an APRF protocol. APRF protocol is where there's a sometimes called as advanced platelet-rich fibrin. Some authors would prefer to call it as an activated. I don't know for what reason, but apparently this activation refers mostly to the activation of monocytes. Apart from leukocytes, APR protocol is also known to have some degree of monocytes as well for defensive purposes. We also have derived protocols based on the centrifugation. As I was telling you, angulation G-force, please remember, probably, at least according to me, it's probably the most important point of the day. The angulation G-force, most of the times, unless you use a PRF centrifuge, the angulation and the G-force is not under your control. Okay. So there have been some protocols where, to basically reduce the G-force and to adjust the angulation actually. So we have had a lot of centrifugation protocols. We have had a lot of changes in the test tubes themselves, where we now have adjustable test tubes, okay, where you can adjust the test tubes nicely. Okay. So this is something that is extremely very, very important. At the same time, cell separations. Okay, so if you remember just the one or two slides, let me just take you to the slide. Yeah, this slide. So the ISTH, this association fundamentally tells us, please move away from centrifuges. Okay, please move from centrifuges. Please try to go into other apparatus, okay, such as cell separators, autologous selective filtration, and this thing and that thing. Okay, so there have been advances in people trying to move away from centrifuges. Centrifuges actually they can create a lot of heat also sometimes. Okay, now, because there have been so many protocols, there's now a new term called as blind pieces. Okay, so we have a protocol. We now have a platelet concentrate for a protocol, but we honestly don't know actually whether this protocol is actually standard or not. Actually, okay, so this is something that is very sort of like unfortunate, considering that we are so deep into platelet concentrates, but some things is not something that are actually under our control. So what are the various derived platelet concentrates that we have? Okay, so one is the classic LPRF protocol that was what do you call given by Chokran. That was also amended by Chokran. That was also amended by Dohan Ehrenfest, and a lot of other authors actually. Okay, where the classic LPRF is where we actually turn or run the centrifuge at 3000 RPM for 10 minutes in a glass coated vacutainer. So remember these vacutainers with red caps. So this was a standard LPRF protocol. We also have something called as a standard PRF protocol. Remember, this was also called as initially this was called as a PPRF protocol. Nowadays, it's being called as a standard PRF protocol. Okay, so this is classically at 2700 RPM for 12 minutes in a glass coated vacutainer. So this is something that I strongly suggest can be followed, especially by most of the PGs. This is almost like a fail-safe protocol. You generally get some PRF or the other with this. Of course, we have an APRF protocol. This requires a special, what you call, armamentarium. Apparently, the developers of APRF say you can't do it in a normal centrifuge, which is fine. But at least for textbook purposes, let me tell you that you basically run this at a very low RPM, not exactly at 3000 RPM. You run it at somewhere, 700 RPM for 3 minutes in a glass coated, uncoated in a glass coated vacuum tender. You also have an injectable form. So I put some pictures actually. These are my own. So if you can actually look at it at IPRF. So you can run something at 700 RPM for 3 minutes. Most of the time, some centrifuges just can't generate IPRF, especially if you are using the Remi tabletop centrifuge. Actually, you just can't get IPRF. You'll get a slight liquidy thing, which is technically not PRF. So let me tell that to you. Of course, for practitioners of implantology, we basically have a lot of protocols to generate sticky bone, stinky bone, sticky bone. So we also have a nice protocol, of AFG, autogenous fibrinous glue, where you actually use an uncoated vacutainer at 2400 RPM for 2 minutes. The derived protocols also depend on a lot of things. So as I've probably told you, right, it is extremely dependent on the armamentarium that you fundamentally use, because I also spoken a lot on, optimizing centrifuges, especially optimizing centrifuges for the thing that itself is a very big topic. I've spoken probably for 3 hours, I think, once, if I remember, once in one of the national conferences on this. But let me do tell you that there are specific protocols, even to obtain a maximum from a normal centrifuge that we fundamentally see. Okay, so what we basically do is there are some protocols. One is called as Anichua's PRGF. So Anichua PRGFs is something where we basically once we run the proper what do you call it, PRP protocol. Once we run the proper PRP or a PRF protocol, we basically try to obtain the layer near the buffy coat, with a little bit of fibrinous layer. We again centrifuge it and take whatever is there at the bottom actually. So that is what Anichua fundamentally said is this has almost like this magnifies the amount of growth factors about 5 to 6 times, which makes it very important actually for you to maybe this is something you can follow, especially if you really want to sort of like get a very nice growth factor mix. There's also something called as Nahita's PRP. Nahita PRP is fundamentally what they basically say is you don't do a double centrifugation protocol, do a single centrifugation protocol. There's no need for a double centrifugation protocol. It is not extremely very popular thing, but there's a textbook protocol, so let's not forget what this is about. There's also something called as SACO CGF. SACO is something that is called as a low speed centrifugation protocol where you actually run PRF but at 3 speeds. One thing, if I remember correctly, is at 2600, then you bring it down to 2100, then you bring it down to 600, all the way down to 600 actually. Okay, they basically say that this slow deceleration actually tends to preserves cells better. Please remember that higher speed means a higher G force, which also means that a lot of cells are going to lyse because of your actions. So a SACO fundamentally has said, that doing it at incrementally slow speeds would probably, help preserve the cells better. At the same time, everything boils down to armamentarium. All the certificates that we do from most of the manufacturers like Remay, like Cyclex, and this thing and that thing. Okay, remember they're called as non-PRF centrifugages. They're basically laboratory centrifugages. Even I use a laboratory centrifuge myself, considering the cost, the proper PRF centrifuge. So you're looking at something that costs you maybe 40,000-50,000 to something that costs 1.7 to 1.8 lakhs. And there are some studies which basically say fundamentally, at least let's say clinically, there's not much huge difference between these two. Okay, so let's not forget that even the armamentarium, to some extent, there are some controversies, but these controversies are not so limiting that is going to affect the production or the usage of PRF per se. The third thing is the various cell separation. As I've been telling you just probably 2-3 slides before, let us, at least not me or not you, but there has been a concerted effort for people to move away from centrifuges. So please, something that we have to, it's a food for thought for us actually, so that we can actually incorporate these things in our setup. So more to the last part of this presentation, which is what are the various issues and what are the, what do you call, some things about the management of PRF protocols and the use of platelet concentrates per se. We see a lot of lot of communications. We see a lot of what do you call clinical material. We see a lot of programs being conducted on PRF. It's also treated like some sort of a magic bullet. Something like you put PRF is you're going to get soft tissue. You put PRF, you're going to get hard tissue. You put PRF is you're going to get bone. You put PRF and you're going to get whatever tissue you want actually. So in what way? So is this thinking fundamentally correct? Actually, for example, let's say I've even seen a couple of articles, case reports that is, where they have put used PRF membrane, and they basically say it also improves the what do you call the gingival phenotype. It also regenerates bone. So is this thinking correct? Actually, can it have a dual action on two very widely divergent compartments? That is one thing. At the same time, what about the quality of the platelet concentrates? Fine, we are taking the patient's blood. We're actually trying to generate platelet concentrates with it. Fine, but actually, so are we? Is the quality standardized? So are we actually correct in doing this? So this is something that we also should look at. And let's not forget that the humans are not exactly clinically sterile. Even blood is not sterile. Most of us know that there are some normal commensals even in the blood itself. Actually, blood carries a lot of microbiota in itself. Actually, so are we correct? Actually, using a platelet concentrate without any forms of disinfection. Okay, so let's think about these three things probably in the next. Not too many slides now. Next 5 or 6 slides. In case if you're bored with this already. Okay. So if you look at most of the articles actually, the pictures are very, very, very divergent. There are a lot of articles which basically say that PRF actually works beautifully in sinus slips, but there's a very, not so recent, but at least 5 years before, there was a very nice meta-analysis of almost close to 28, 30 studies on the use of PRF. I've just left the references below, so kindly have a look. So they basically say that PRF in sinus slip again is a very, very questionable entity, primarily because, PRF is a clot. Fine, this clot can stay stable for 14 or 15 days. But if you look at bone regeneration, we are looking at it's an intense activity for from 3 to 6 months. So they basically say, please give it a thought whether you can only purely use PRF in sinus tubes without adding anything. They basically say that they don't say that PRF is totally useless or something, but they fundamentally say that you have to add something with PRF to improve the stability of this clot. Otherwise, this clot is not going to stay there for 3 to 6 months for an entire bone regeneration. Even socket preservation, very surprisingly, actually, where a socket is clinically it's a very stable defect. Okay, but still there are a lot of studies which basically say that if all the walls are intact, they basically say PRF is useless. Why? Because if all the walls are intact, then the clot is going to be stable anyway. Why do you want to add PRF in a situation where the clot is stable in itself? At the same time, if the clot is missing one or two walls, there's no point in just using PRF. Why? Because again, you're looking at a very intense heart tissue, what you call reparative activity. That PRF must be stabilized with something. I'll just show you one slide where I think this concept should be driven home probably. And they basically say that even for socket preservation, where the walls are intact, where the procedure is very easy to do, the success rate is just 78%, especially for periodontics. If you look at any meta-analysis actually on PRFs, actually, this sentence is very common. Further studies are still needed to confirm these results. So probably you will definitely see 20,000 or 30,000 articles on the use of PRF in perio, but this statement is something that makes an appearance in everything. There are still some ifs and buts actually, if you fundamentally, look at it to actually understand, you know, what you should be doing, especially when you plan to use PRF fundamentally. One such very thing, especially again for periodontists here, fundamentally is one the European Federation of Periodontics itself actually. Okay, so they basically had a what do you call a sort of like I guess a conclave on bone regeneration especially one of the things that they targeted is the efficacy of platelet concentrates, especially the use of PRP, the use of PRF, the use of PRGF, okay, the use of plasma rich in growth factors, the use of platelet rich fiber, the use of platelet rich plasma. Okay, so they basically sort of like concentrated. They basically concentrated on 4 procedures: rich preservations, rich augmentations, peri-implant bone defects, and sinus augmentation. Okay. Maybe with rich preservation, the results were just about okay. They could not really find a lot of sort of like controversies. With respect to rich augmentation, they basically said, unfortunately, we have no randomized control trials. We don't have too many huge randomized control trials on this, so we can't actually come to a specific conclusion. Okay, this was in 2019. I hope there was some, sorry, I did not search especially for this regard as such, okay? But at least until 2019, they basically say for ridge augmentation, we are not able to find a very good, sort of like randomized control trials or prospective control studies, especially, okay? Surprisingly, even for peri-implantitis, actually, they basically said there were no controlled clinical studies. Most of them were anecdotal, or most of them had some sort of a selection bias or even investigator bias to some extent. Sinus augmentation, something that I just spoken a slide before, actually, they basically said there's only one split mouth study again with the proper histology studies, only two studies or two patients, if I'm not wrong. So they gave a lot of conflicting pictures, saying like there's so many studies now, but at the same time the studies they don't seem to have a very good weightage. There seems to be some ifs and buts that any investigator or any clinician who's actually using PRF must be doing it at his or her own discretion. So this is something that they fundamentally said when they were speaking about PRF. I was just speaking about why PRF is or PRP for that matter is a bit controversial with respect to especially heart tissue augmentation procedures. So there is a very nice law called as Liebig's law of minimum. Liebig's law of minimum is, if you basically look at, this is actually a whiskey cask. I'm pretty sure all of us can recognize that. Okay. So if you fundamentally looking at it, so there is a very nice principle. Okay, I'm sure periodontists and most of the perio-PGs, if you're there, you'll recognize this principle. Okay, which is called as a pass principle. Okay, where we are looking at four things: primary closure, angiogenesis, cloth stability, space maintenance. Okay, so for you to get a proper predictable bone regeneration, all the four things are important. You should get primary closure. That compartment, that regeneration compartment, should demonstrate proper angiogenesis. That PRF that you're putting should be stable. That PRF should not show any micro movement. Micro movement is not just for implants. Please do remember, it's there for every regenerative material, right from bone grafts to PRF. The PRF plot must be stable, must be stabilized, must be sutured. You should also have a proper space maintenance. Okay, so do remember, it is not wrong putting a GTR or a GBR membrane over your PRF membrane. Okay, so this you should demonstrate some sort of space maintenance. And please remember that this should not be broken. In fact, the efficacy of your PRF is going to be the shortest shard, actually. If you look at it, this thing is shortest than the other three. Okay, so if your clot is not stable, even if you have obtained a proper primary closure, angiogenesis, and space maintenance, you're going to lose some degree of regeneration. At the same time, your clot may be stable. It's a wound that shows a lot of angiogenesis. Fine, you put a membrane. But if your closure is not proper, please do remember that your PRF is not really going to work very well. Okay, so in fact, there's a very nice saying, for NBR. NBR is, I'm sure most of you know about what is GBR or your guided bone regeneration. NBR is something called as natural bone regeneration. Natural bone regeneration is instead of using a collagen membrane, atelocollagen membrane, telocollagen membrane, PTFE membrane, this membrane, that membrane, you can also use PRF as a membrane. Okay, so the use of natural products, the use of autogenous products for as a GBR material is sometimes called as NBR, and a lot of articles categorically say that for you to get a proper NBR, you should be getting a nice primary closure. Okay. At the same time, a lot of people will basically say, that fine, PRF is greater to a clot. PRF is greater than a normal clot. At the same time, this will only do if the compartment shows a very nice angiogenesis. Okay. And especially if you're not doing space maintenance. Okay. Let's talk about, extraction sockets. You have a very big extraction socket, you just put a PRF and then try to get primary closure. It's not going to work because there has to be some degree of space maintenance. Even the PRF is very vulnerable towards the gingiva actually growing into this compartment. So this is what this principle basically says. Okay. At the same time, let's not forget that platelet concentrates have a lot of growth factors. We are looking at PDGF, we are looking at VEGF, we are looking at EGF, we are looking at IGF, we are looking at EGF. So all these actually they have to work, and they work by themselves. In fact, articles categorically say again that please don't combine with PRP, especially PRP or PRF in any other growth factor with any other growth factor. For example, they basically say that pure PRF is probably the best. Okay, something slightly better than that is actually you can combine this PRF with an alloplast, not even with an autograft or an allograft or a xenograft. Actually, what is basically said is if you look at this picture, when you have something like a bell shape, actually, okay, the peak regeneration is obtained only by two things. First thing is by PRF, and if you combine this PRF with alloplast, especially to give it some stability. Otherwise, a lot of articles basically say that if you actually try to combine it with an autograft, even with an autograft, with a DFDBA again is an osteoinductive material like an autograft. Okay, if you basically say that if you try to combine it with any other growth factor in the mix, actually, unfortunately, the the studies, they don't seem to be extremely supportive. Okay, of course, it makes for a good procedure. There's nothing wrong in adding autograft and PRF, which actually forms a peak here. If you basically look at it, the peak is actually with an autograft with a PRF, followed by an alloplast with a PRF, followed by PRF. But if you try to add any other growth factor, apparently there is going to be some degree of conflict at the biologic level or the molecular level or whatever. But unfortunately, even with titanium meshes, the concepts, the what do you call? If you look at most of the studies, actually they tend to create a very different picture on what we basically expect. As I was telling you, that growth factors are actually growth factors. PDGF is a mixture rich in growth factors. For growth factors to work, they should actually interact with receptors in that specific level, and the receptors are not there, your growth factors are fundamentally not going to work. In fact, actually, right from 2001 to 2024, there have been a lot of articles which have tried to identify whether these receptors are actually present in the regenerative compartment itself. For example, let's say you have a bone defect and you want to put PRF. Okay, now you want PDGF to act, you want EGF to act, and you want IGF or FGF to actually act. But these things won't act if the receptors are not there. Okay, so fundamentally, a lot of articles have said that fine. One good news for us is the main growth factor in PRP or PRF or all the platelet concentrates is our platelet growth factor or something called PDGF. Luckily for PDGF and TGF, most of the tissues they demonstrate response, which is actually quite a good thing. So because luckily they have receptors, so we can be sure that the growth factors won't work. EGF is something that is a hit and a miss. Some articles say that EGF receptors are found in the periodontium and in the alveolar apparatus. Some articles say it's not really found that much. Okay, so this is also some sort of you can probably say you can give it a 50-50 chance actually. But if you look at IGF and FGF, unfortunately, a lot of articles say that, especially for PDGF receptor are actually alpha. So basically, even PDGF R alpha, R beta is present, but R alpha again is definitely not present for some reason. Especially a lot of studies will say that PDGF R alpha, IGFR, and the receptor for FGF, unfortunately, they don't seem to be present in alveolar apparatus. Okay. So if you're looking at an article which basically says that, we have found bone regeneration and we have also found a very good improvement in the gingival phenotype, I think that requires a bit of a thought because, when the article says that there are no receptors for FGF, how is it going to act? But what was said and done? So these are something that, a practitioner of platelet concentrates must fundamentally keep it in mind. Of course, there's a lot of things that are going to that are going to be important with the quality of platelet concentrates. Okay, so how do you collect blood, especially? Okay, are you using a normal 10 ml needle? Okay, are you using a butterfly needle? Are you using what you call a lag needle? Okay, are you using a vacuum retainer with what you call a proper, a butterfly tag and this thing and that thing? Okay, so all these things will come into account. Okay, so something that I've been telling you probably in the last 10 minutes or so. Okay, so what sort of centrifugation? Okay, what is the nature of the tube? Is the tube self-cooling actually? Is it made of metal? Is it made of plastic? Is it made up of polycarbonate, which is actually heat resistant? Okay, how does it rotate? How does it accelerate? How is it stable? How does it decelerate? Okay, the condition of the centrifuge actually, your centrifuge must be calibrated once every 6 months. So if you put a centrifuge and if your centrifuge is moving all around the clinic actually, so it is something, it's time for you to get it serviced. Okay, if you're not doing that, you're definitely compromising on the quality of the centrifuge that you are using. At the same time, the handling of the clot itself. Okay, so are you pipetting it out actually? If you are using a two-stage centrifugation protocol, okay, are you going to pipette out actually? How are you ensuring that the coagulation is proper and this thing and that thing? Okay, so all this, for example, from our own department actually, when we did a study fundamentally, okay, so before we had a centrifuge in our own department actually, we had it in a central implantology clinic actually. So we had to take the blood and our PG or someone had to run to the centrifuge actually. Okay, so it actually creates a lot of difference. For example, let me show you 3 examples. In fact, from the same quantity from different patients. Okay, different patients can be a sort of a limiting factor. But when we waited for 2 minutes and then put it in the centrifuge for 8 ml of blood, this was the FGF that we could get. When we waited for 1 minute, slightly better. When we waited for 30 seconds, this was how it was. Okay, so there is going to be a very nice, huge difference, between there is a big difference. So this is something that all PGs and all practitioners must really inculcate a habit of drawing blood as quickly as you can and a habit of transferring it into, a pipette or wherever in the tube as soon as you can and to run the centrifugation cycle as soon as you can because that is actually a very big limiting factor. Another topic that is unfortunately very outside the purview of this presentation is, that Your centrifuge, the centrifuge that you do, was just doing the chats in between actually. So I think there are a lot of questions on what sort of centrifuge must be bought actually. So please remember that we have two types of centrifuge. Okay, we have two types of centrifuge, which is called as the fixed angle centrifuges, where the tube actually, if you look at this picture, the tube angle is actually standardized. And we have something called as the swinging, what do you call it, bucket centrifuge, swing bucket centrifuge, or a swinging bucket centrifuge, okay? Where the tube actually is perpendicular to the axis of rotation of the main rotor, actually, okay? In fact, nowadays, fixed angle centrifuges can be considered as PRF centrifuge. Okay, the G forces are another matter, but please remember that the tube angle should be between 14 to 40 degrees. Preferably, it should be 37 degrees, not even 40 degrees, actually. Okay, whereas swinging angle centrifuge is 90 degrees. It's very easy to understand, actually. Okay, so if the centrifuge is exactly perpendicular, there's going to be a lot of G force. It's going to crush your clot, actually. Okay, so your clot size is going to come down. Okay, please remember that we have done some work actually on this. Okay, so if you want to buy a centrifuge, so please make an effort to buy a PRF centrifuge rather than a non-PRF centrifuge. Okay, so this is a very big factor because these are the pictures I took from all the clinics that I go in Hyderabad actually. Okay, so the variety of centrifuges people have. So geocentrifuge is something that is actually a PRF centrifuge, especially optimized fundamentally to get PRF is very expensive. Okay, at the same time, I've had a lot of experience with all the other centrifuges as well. Okay, centrifuges. This is a PRP centrifuge actually. An Attico centrifuge is a non-commercial PRP centrifuge. This is a cooling element. In fact, below the ceramic thing is a cooling element where you can actually cool the blood preparation. Even in our department, actually, we have a very classic REMI 8C, actually. Okay, we have a REMI 4C also, which is a fixed angle centrifuge. So it all boils down. If you're very skilled at drawing blood, please do remember that give a thought to the centrifuges as well. Let's not forget the important attributes of this. Okay. So the last aspect, I'm going to just take 1 minute. Let's not forget that we are drawing blood. Blood is not a very sterile fluid. Okay, I'm sure most of us know there are a lot of what you call blood-borne microbes that we have in our body. So they have a potential. There's been a lot of studies actually where they've been investigating whether this can actually impact a wound, which is quite possible because we have a lot of staphylococcus bacteria which have an impact to what you call reduce what you call efficiency of wound as such. Okay, so a lot of thing were used actually. UV light was one thing. There have been concepts where you can actually sterilize PRF using UV light. There's a concept even in trying to use riboflavin and even I'm not very sure what is ampicillin is. I tried to find out for some reason could not get a proper thing. Apparently, it actually cleaves all the bacterial what you call genetic material. At the same time, you can also use it in all the blood products as such. Okay, so from our own department, actually, we have tried using methylene blue. Okay, so what we did was actually it's sort of like just one drop of in the blood that we basically draw, one drop of methylene blue. Actually, just put it in and nicely, sort of like run it in a centrifuge. You can actually use a normal what do you call your LED gun actually to put it on the PRF. This is an injectable PRF. I hope you have seen that. It's an IPRF syringe actually. So just put not even half a drop of methylene blue in an IPRF syringe actually, and sort of like sterilize the entire PRF. So this was one study where we are helping another person. So if you look at these cultures actually, so we actually slightly take digitized pictures of the cultures because we were using and doing an image analysis. So this is actually all these are actually flattened PRF membranes. This one and this ones. So we actually treated them with various antibiotics. Here actually we put augmentin in the patient's blood, and once we actually cultured, you can actually see the zone of inhibitions here actually. So this is actually A culture. This is actually a complex, no, actomystum, actomystus concept, competences thing, and this is actually our PG, your Porphyromonas gingivalis thing. Okay, so you can actually see this very nice sort of like, zone of inhibitions actually in both the thing. Okay, again, thank you all because on a Sunday morning, thank you for spending time with me. At the same time, let's not forget, the platelets at the time were sometimes very underappreciated because they were only thought to sort of like, help in body's reparative mechanisms, where they just form what do you call a hemostatic plug. That plug is going to sort of like what do you call resolve into a proper wound. But luckily, what we have seen from the past 40 and 50 years is actually a lot of things actually, where platelets have moved from just playing a sort of like a very passive role in repair in the forefront of bone regeneration. So this is something I think most of us should consider, especially today's takeaway points. Probably is one thing that I would like to tell you is kindly look at your centrifuges. That's one thing. At the same time, let's also try to optimize the protocols that we do. Okay, let's try to what do you call sort of like especially when we draw blood and we try to from the time of drawing blood to taking it into a centrifuge, let's sort of like try to uh, improve our speed, especially when it comes to this. Okay, so with this, I conclude my presentation, and thank you so much for your patience.
Thank you so much, Dr. Vishwa. So I request our moderator to ask any questions. I think few questions have been posted in the chat box. So
Yes.
kindly.
Thank you, sir, for
Rising
that
case of osteoporosis,
very well
is there any
presented
complication in
topic.
osteoporosis?
Thank you.
There are a few questions. One thing is,
Yes.
I think you have already answered, sir, that which
Yeah.
centrifugal machine has to be used, all that.
Yes, sir.
Then one more question was there on the grade of titanium for titanium PRFs.
We basically the titanium tubes. So, for example, I know that most of them procure what do you call titanium tubes from Turkey, because Dr. Tenali actually, who's the person here, actually he was the one who basically introduced the concept of TPRF. So because I'm in Hyderabad actually, so we have a DRDO, the Defense Research and Defense Organization labs actually. So we were able to obtain a lot of TPRF tubes actually. Okay, so when we asked them what grade titanium were the tubes are, they basically said these were actually they're grade fours of there are four types of titanium, grade 1 to grade 4. So we actually got titanium tubes which were grade 1 to grade 3 and grade 4. So that was what we got. Apparently, to make a grade 1 titanium tube, you have to get a clearance from Government of India, which is not possible. So so that's it. So it's grade 3 and grade 4 titanium, sir, actually. So that would be the answer for that.
Thank you, sir. Thank you very much. I think there was one more question, sir, on
Yes, sir.
CGF, more about
CGF
CGF
membrane.
membrane.
Concentrated growth factor, actually, this question was by Dr. Ranjana Deshmukh. Okay, so CGF protocol is sometimes called a SACO protocol, ma'am. Actually, SACCHO. I mentioned that word somewhere, a SACO protocol. SACO protocol is something, if you remember, I basically told you that a PRF protocol is from 2400 RPM between 10 to 14 minutes. For CGF, actually, the protocol is much more lower. What you have to do is you have to run the centrifuge at two speeds. The first speed is at 2000 RPM for 6 minutes. Then you have to wait for about 30 seconds. Then you have to run it for 1400 RPM for another 1 minute. I hope this is clear to you. 2000 RPM for about 8 minutes. Then wait for about 30 seconds. Then run it at 1000 RPM for about 1 to 2 minutes, actually. So that is the protocol. CGF actually is concentrated growth factor protocol. This is sometimes used to generate sticky to stinky bone, actually. Okay. So in fact, I would ask you to search for something called SACO protocol. If you don't remember what I've told you. So SACCHO, SACO protocol, it would tell you something about, the CGF, this thing.
Sir, there is one more question on is there any complication on osteoporosis patient?
This is by Dr. Rahul Chandra, because I don't remember actually, and this is not a question I can even answer right now, sir, because I did not really understand the ratio of the question. Why should there be a complication in osteoporosis patient? So if you can tell me that, probably I can answer it in that way.
Okay, sir. There is one more question. How long after preparation should we use the PRF?
I think this question used to come when there was one very famous Viva question, sir, in Perio is, once you put PRP, should you use PRP immediately or should you wait for some time, actually? So at the time, the answer was 1 minute, because people used to say that, there's a lot of complement activation, even in a blood clot, actually. So there's a lot of complement activity. The same complements, so COM, PLE, MENT, the same complement actually that we have read about. So apparently this complement activity ceases. So once you finish off the centrifugation, once you take the PRP or PRF outside, this complement activity will cease or will stop after 1 minute, actually. So for PRP, apparently you're supposed to wait for 1 minute before you actually manipulate the material in any way. But PRF, actually, this concept is not there. Primarily because PRF, apparently, because the centrifugation cycle is very slow, very gradual, there's nothing added. the clotting system also is very slow and gradual. There's not much of appreciable complement activity. So you don't really have to wait. There's no clear-cut waiting period actually. So you can, the moment it is done, you can remove it and you can use it. So that is what it is basically said. And the storage is actually for one. I think this same question actually is what is the storage protocol? Storage protocol for PRP is about 1 minute. He basically said you can store it for 1 hour. After 1 hour, if you're not putting it in the tissue in an extraneous environment, most of the growth factors, they appreciably fall. You don't see the growth factor release for about 14 days. For every hour of active storage, it falls for 50%. What is said is, if you put the clot outside for 1 hour, the growth factor release is going to be only there for 7 minutes. That's all. So that is what it's basically said. 7 days, sorry, 7 days, yes.
Sir, there is one more question, how to calculate G-force to RPM?
So that's I spoke about this a lot of times, sir, actually, but I'll definitely try to share a small PPT on this with Dr. Manuel. I'm pretty sure he will actually see that it's reaching to the concerned person, sir, because there's a formula involved. There are centrifuges actually where you can adjust the test tube length actually. So based on whatever G-force that you want, there's a very standardized formula. There's a standardized formula between what do you call the G-force that you want versus the what do you call versus the RPM that you want actually. So based on this formula also includes the length of the tube actually. So you can actually adjust the length of the tube and adjust the RPM to what do you call gender. I'll share a very small handout with Dr. Manuel. I'm pretty sure, sir, Manuel will share it with all others so that this is actually this reaches the concerned person, definitely.
Okay,
Yeah,
thank you very much, sir. I think the questions are done now.
Thank you so much, Dr. Mahesh, for moderating the session. I think it was a very beautiful session where most of the queries were answered. So I would really like to thank our speaker, my good friend, Dr. Vishwas, for sparing his
thanks
time
thanks so
and
much,
sharing his expertise. So thank you so much, Vishwa, for
thank you, Manuel. Thanks so much.
spending time with us on a Sunday morning.
Thank you.
And to Dr. Mahesh, thanks a lot, Dr. Mahesh, for being the moderator. And thanks to all the participants for, coming in good numbers. Our limit was 100. We hit the limit of 100. So those who are ISPRPians, members, I have shared the YouTube link. You guys can watch the presentation even in the YouTube through YouTube as well. It will be available for another 2 to 3 days. These are our upcoming events. These are our upcoming events. We have in June one more a webinar that will be on bleaching. And then obviously, as Dr. Siddhi mentioned, we have our national conference, the 14th national conference in Ghaziabad. So kindly register and make this event a success. So thank you so much, everyone. So before I conclude, one more good news, which I shared last time, our journal. Our Journal of Interdisciplinary Dentistry has become Scopus indexed. So please do send interdisciplinary original research articles to the journal for reviewing. And the last, for getting your certificate, please fill in the feedback form. I've shared it in the group. I've shared it in the chat box as well. I will also email it to you. Fill the feedback form and automatically your certificate will be available, will be emailed to you. So thank you once again. Thank you, Dr. Vishwa. Thank you, the participants.
Thank you, Manuel.
Thanks a lot. Have a nice weekend.